It was a wonderful, once again listening to Dr. Mohan sir on e-GNAM, and when I got an opportunity and honor to speak somewhere where there was empty slots, so I said I'll talk on the same topic, so we have a continuation on the same concept and something on something original on the management issues or management learning on gestational diabetes. Is it working? Yeah. Thank you very much, Bansi Bhai and the whole team of Diabetes India. I don't know. It's not working? Okay. So there is no conflict of interest for this particular session. I'm going to talk on introduction. Some newer concepts and classification has already been discussed. We have one or two more things on just summarizing those points. Recommendations in the Indian data on pharmacotherapy in gestational diabetes. I feel everyone knows that the prevalence of HIP is increasing. Almost 85% are going to be gestational diabetes, around 15% are going to be pre-gestational diabetes. And pregnancy is being considered as a stress test to the beta cells, and they are likely to develop diabetes in future. I feel everyone is aware of this particular slide. Important is this is one of the window of opportunity that we can unfold these women who have compromised beta cells and are likely to develop diabetes in future. So that is why recommendation said that every woman at the first given opportunity, and that also Dr. Mohan said that the first time when they are being diagnosed to have pregnancy should be screened by GCT or OGTT, so that you can unfold this mystery of hyperglycemia and pregnancy. This is a classification by FIGO that HIP has been divided into two: DIP, which is diabetes in pregnancy; gestational diabetes, which is diagnosed during pregnancy. So DIP is one category where you have known type 1, type 2 becoming pregnant, or those who are diagnosed for the first time during pregnancy because they have never tested it, but it matches with the cutoffs of the known of the diabetes, like 200 post glucose, or fasting more than 126, or random blood glucose more than 200, or HbA1c more than 6.5. Then they are known or pre-existing diabetes, but they have never tested it, and that is again DIP, because the treatment strategies they change as per the classification of hyperglycemia and pregnancy. Well, GDM is typically coming, which is being told to you. So your GDM, which refers to hyperglycemia between 24 to 28 weeks of gestation by the standard criteria. Either you go for DIPSI guidelines or the Government of India guidelines, or maybe the international guidelines, and that can be called as conventional GDM. So it's CGDM now. Overt GDM is those, as I told you, pre-existing diabetes but never tested but diagnosed during pregnancy. They are overt diabetes. EGDM has been just discussed, that you are diagnosed hyperglycemia in pregnancy before 24 weeks. Mild GDM is another terminology where you do 2-hour test between 120 to 140, because your cutoff for targets, glycemic targets, is 120. So anything above 120 is going to be abnormal. And pregnancy is being celebrated in our country, so one should know that if you tell the women that your blood glucose is 135, you don't have diabetes, she is going to do this GCT on a daily basis by having sweets, because we celebrate pregnancy, and that might cause a problem to the baby, and that's why mildest form of hyperglycemia should also be respected. So it's an epidemic, and these offspring of diabetic mother, they are also likely to develop diabetes, and these women are likely to develop diabetes and future cardiovascular disease risk. This is very important, a new thing which I wanted to share with you. There is a parental contribution of programming adult obesity or diabetes in the offspring that start pre-conception. So pre-conception, you have oocyte maturation, follicular development. During conception, that is fertilization of the embryo growth, and gestational sucking, that is lactation. These are the critical windows of the maternal and obesity and diabetes. And this is animal study. There is also important message that pre-conception period, even the quality of the sperms, that also important for the outcomes. So pregnancy is a multiplier of unfolding pandemic of diabetes and NCD, and we should know that it's a crossover, and it's a vicious cycle which may continue. Is there any role of gut microbiota? So there is some data now that we call it as gut dysbiosis, which might have, which has been shown in GDM women. There's some good bacteria which are less, there are some bad bacteria which are more, and they might increase the maternal fasting blood glucose, maternal BMI, and they are pro-inflammatory to the baby and may cause obesity in the offspring. And this is a wonderful diagram showing you multiple, some good as well as good microbacteria which are becoming less, and some of the inflammatory mycobacterium which are going up, and they are causing some changes in the milieu, and they might be responsible for the childhood obesity in these babies who are born to these mothers. Now, and this is a vicious cycle, as I told you, which might continue. You have got a woman who's obese, delivering a obese baby, and if this turn out to be a female, will again become a obese women and obese pregnant women, their next generation. And this vicious cycle has to be taken care more aggressively and more seriously, which we are not doing at this moment of time. I'll have just 30 seconds on screening. So we have this ADA criteria, IA, DPSG, WHO, and most of them they follow IA, DPSG criteria now, that you do fasting more than 92, give 75 gram glucose, 1 hour is more than 180 or 2 hour more than 153, we call it as. Now you have Government of India guidelines updated almost 8 years back. And they have simple criteria of DIPSI that gives 75 gram glucose irrespective of the time of the meal. If the 2 hour blood glucose is more than 140, you diagnose it as GDM. But if it is between 120 to 140, you can call it as a borderline case or a GGI, gestational glucose intolerance. So they need to be kept very close follow-up. When it comes to the management part, glucose traverses the placenta with the passive diffusion, so it directly goes inside the fetal circulation. Same is the amino acid, same is the ketone. So if the mother develops ketosis, ketone will enter into the fetal circulation directly without any hindrance. Triglyceride partially will need some receptors. Insulin doesn't cross the placenta. My message is, insulin doesn't cross the placenta, but all other oral glucose lowering therapy, they do cross the placenta. Glucagon also doesn't cross the placenta. And that is why that insulin becomes a drug of choice. So you have insulin drug of choice. Oral drugs, we are using metformin. Glibenclamide has also been approved. And of course, diet, lifestyle modification is one thing. The insulin, we have now, except glulysin, most of the insulins are being approved. As far as glargine the debate is concerned, we know that the glargine, now they say that if a clinician has already put the patient on glargine before conception, women comes to with pregnancy, and if you feel that by withdrawing glargine, it might affect the glucose control of a woman, in that situation, on clinician's perspective, we can continue glargine. Degludec has also been approved recently, last year, for use in pregnancy. Their target should be 90, fasting less than 90, 2 hours should be less than 120, HbA1c should be less than 6.5, and this TIR model has been shown yesterday also in the technology meeting, that for GDM and type 2 pregestational diabetes, the cutoff actually has been kept in pregnancy 63 to 140. I repeat, 63 to 140 is the TIR values. For GDM and pregestational type 2 diabetes, should try to achieve more than 90% of TIR, while for type 1 diabetes, up to 70% TIR is acceptable. Your targets, as I told you, will be target for pregnancy, I told you. Then we have, this is one paper which I wanted to share, because there's the Indian data where we are going to have some guidelines, some message that how should we proceed once a person women with GDM comes to you after diagnosis. So it's a neonatal maternal outcome in women treated with insulin or diet, and it's a propensity match analysis. The highlights are that women receiving insulin had a low risk of preterm babies, low birth weight, and macrosomia. So they have less risk of having LBW and macrosomia. Neonatal hypoglycemia was more common in insulin treated women. 2-hour glucose tolerance test of more than 162.5 and the fasting of more than 90 are likely to require insulin. Individual with the propensity score of more than 0.7, that I'll tell you what it is, require higher dose of insulin versus others. A study has concluded that individual with bad obstetric history, family history of diabetes, obesity and elevated baseline glycemic parameter, that means fasting, postprandial, post-glucose or HbA1c are likely to require insulin. These are the baseline characteristics. So those women with higher age, having bad obstetric history, having positive family history, and having pre-existing BMI high are likely to require more insulin versus others who are managed only on diet. And neonatal hypoglycemia was found to be higher in women who were on insulin therapy. PIH was more common in women who were receiving insulin. And this is again then after we did the propensity score and the adjusted risk of neonatal and maternal outcome, almost everything was similar. That means whether you give diet or insulin, if you select the patient properly, it is the only risk of with hypoglycemia is neonatal hypoglycemia, which is expected because these women are having severe hyperglycemia and they are requiring insulin to achieve the glycemic control. Rest all other things were similar. That is another very important message. People have an apprehension that if you give insulin, women might end up into hypoglycemia and you might end up with having IUGR, and that was one of the concern which was raised, that are we over-treating these women? But the study has shown if you properly select the women and treat them effectively to achieve your targets, you will not cause over-treatment. There is no increased risk of low for gestational LGIs. And then preterm birth, so what we have is the preterm birth, low birth weight, macrosomia due to insulin were close to 1, that was statistically not significant. Neonatal hypoglycemia 4.43 higher. LGA was comparable, rather lower in the patient who received insulin. IUD was also found to be lower, and PIH was little higher in insulin treated group. Now, we also did initial and the full-term dose required for these women during use, and the first to the third, they have divided these women who are 386, have been divided to 4 different groups, and this 4 quartile, the first to third quartile signify a low or moderate risk, while the 4th quartile has higher risk factors. And that's why this is a love plot. This love plot is, if you see on one side, this is, I'm sorry it's not working, but then I can use this laser pointer if I can, yeah. If you see this, I don't know, no, it's not, yeah. I'm able to not move, yeah. Okay, so this is the, if you see this is unadjusted, this is adjusted. In all of them after adjustment, this plot seems to be more overlapping, and that is called as love plot, yeah. So what they have done is, this first, second and third quartile, what they have adjusted is the age of mother, parity, BOH, family history, pre-pregnancy BMI, HbA1c, fasting and 2-hour postprandial. These 3 quartile having less than 0.7 versus the 4th quartile had a propensity score of more than 0.7. Now these have required almost 10 units of insulin on an average in the initial stage, which ended up with almost 18 to 20 units of the insulin at the time of delivery, while this group having higher risk factor, these risk factors requires around 17 to 18 units here mean, which went up to 25, which was statistically significant. So this is another message that a 2-hour has highest discrimination power at 162.5 and the fasting as 90, almost 90. So we can easily say that these risk factors, they determine the dose of the insulin also and requirement of the insulin also. So discussion from this particular paper is, it has been observed that mother with over 25 years history receiving, were predominantly receiving insulin. Those younger women were commonly prescribed diet therapy. Presence of family history, then you have 2-hour postprandial HbA1c, higher age, positive BOH, positive family history, they all require insulin therapy. Now, beta cell function declines within 2 years postpartum in women. So, we say that 6 weeks, 6 months and the once in a year, we should be following these women for developing type 2 diabetes in future. But within 2 years, if they say there is deterioration in the beta cell function. And what are the risk factors? You have fasting, antepartum fasting hyperglycemia, early gestational age, postpartum weight gain, decline and the postpartum OGTT, all of them they actually determine the chances of having or predicting the postpartum diabetes, and these are the risk factors. Antepartum, if your blood glucose more than 200, requiring insulin therapy, more BMI, and the diagnosis of GDM less than 24 weeks, that's eGDM, they are likely to develop diabetes in future. And higher is the risk factors, more risk factors, higher is the risk of developing diabetes in future. And this is our own paper, where 16,000 total patients, out of them almost 30% women, 6.6% had past history of GDM. They are type 2 diabetes coming to us, we have taken the past history of GDM. So then we saw the onset of diabetes in these women were around 40 years, and there was a 10-year gap after developing GDM. But then we further went into detail, we found almost 51% of the women of them developed diabetes in the first year after they developed GDM. And the risk factors were those who require insulin were postpartum BMI, and those who required insulin during pregnancy have developed type 2 diabetes early. This metformin plus insulin for pre-existing diabetes on GDM in early pregnancy, and this is a MOMPOT RCT trial where they have used metformin along with insulin and found to be safe as far as use of metformin is concerned. And that's why after these few trials, European government has approved metformin's use from the preconception till delivery. Of course, still we have little pros and little cons of using this drug. Metformin still have a little risk of having low birth weight and catch up growth after the birth. So we have to be attentive, we have to be screening every woman, we have to be focusing on fetus for the future of future generation, because if you detect them early and if you treat them early, possibly we'll be able to save future generations. And that's why we have National GDM Day, which is 10th of March, which is coming very soon next month. And we have 9th of March, we also have the National Dipsy at Hyderabad. So this is a National Awareness Day, and India is the only government in across the globe. Indian government has put this as a National GDM Day for awareness. And I'm happy to share that we have started this Prega Talk, where we have almost 23 languages in the Indian Constitution, and we did almost in all the languages have been covered this Prega Talk. We use regional faculties and do this work. Like if you have Marathi, we utilize the services of Shashank Joshi, and if you have Gujarati, we utilize Bansi and his team. So we do this program for the regional awareness about gestational diabetes. We started now the second cycle. We already have completed almost 19. Very next is going to be Manipuri and then Urdu. So no single period in the human development provides a greater potential than pregnancy for long-term payoff via a relatively short-range period of enlightened the metabolic manipulation. And that's why we should be aggressive in achieving screening and achieving the good glycemic control in these women, irrespective whether you use diet, whether you use lifestyle modification, metformin or insulin. Wish you all Happy New Year, Happy Valentine's Day. Stay safe, stay healthy, and keep smiling always. Don't cut cake today, even if it is for your Valentine. Cut the watermelon, or you can cut papaya or some other fruit to celebrate your occasion and give a strong message to the society. Thank you very much, Chairperson. Thank you.